Okay, we're just coming up to 10:30 now, so I will start the introductions to our second presentation of the morning. I'm delighted, first of all, to say how many of you are with us today, and you're all very welcome. And I'm particularly grateful to the many experts in self-harm and suicidal behavior in young people who have agreed to speak at our conference this morning. We're lucky to have such leading international experts share their research findings with us. So the next presentation is from, and my apologies, Galit, I'm sure I am totally corrupting your name here, Dr. Galit Gyulayov.
Yeah, almost there. Thank you very much.
That with an Irish accent, it's
no, it's a pretty good try. Yeah, it's Gyulayov, but I'll mention it in a minute. So thank you very much.
Thank you very much. So Galit is a postdoctoral researcher in the Department of Psychiatry in the University of Oxford. She works as part of the multi-centre study of self-harm in England, which aims to conduct a series of related studies on the epidemiology, causes, clinical management, outcome, and prevention of self-harm. And also in the presentation, although not visible to us at the moment, is Professor Keith Houghton, who is a professor of psychiatry and director of the Centre for Suicide Research at Oxford University. Keith, welcome, we can see you now. He's a consultant psychiatrist with Oxford Health NHS Fund Trust in the UK. His research group has been conducting investigations concerning the causes, treatment, prevention, and outcome of suicidal behaviour for over 40 years. In recent years, his group has taken a particular interest in investigating self-harm in children and adolescents, and we are absolutely delighted to welcome you both here this morning. Thank you so much for your contribution. And I know, Galit, you are speaking first, I think, so I will hand over to you.
Thank you very much. Thank you. Thank you and hello to everyone. What I'm going to do is I'm going to switch off my camera just in case my internet connection fails me, and so I don't want my presentation to disappear. I'm going to be back afterwards. Okay, so thank you, Eilis, for this very nice introduction of us and our work. And yes, my name is Galit Gyulayov, and I work in the Center for Suicide Research in the University of Oxford. And thank you for inviting us to share our research in this forum. So what I'm going to do in this session, I'm going to first talk about, give an overview, a very brief overview of the area of self-harm in children. And then I will present a paper which we published recently on children who self-harm and present to hospitals in England. And that is from multi-center study of self-harm, as Eilis mentioned. After that, I'm going to hand over to Keith Houghton for further discussion. And at the end of our two sessions, we're going to have time, hopefully, for some questions and answers. So we know quite a lot about self-harm in adolescents. There are many studies around there if you do a literature search. However, it's quite surprising that we know very little in relation to self-harm in childhood, but it is recognized that self-harm does occur in these age groups of pre-teens, and we have several sources of information that shows us this. So we have some data on suicides in children. Not too many of those. I identified one in the US, but of course, suicide is very rare in this age group. And there are data on children who are receiving psychiatric care, whether it's in hospital care or some outpatient care for various psychiatric conditions, and they also self-harm. But again, these data are very dated from the late 70s and the early 80s, and in the US. There are a handful of studies on children presenting to general hospitals after they've self-harmed. We identified maybe a couple. And some retrospective studies which actually asked participants to recall when they started self-harming. And actually a significant proportion of those had started self-harming already in their childhood. And finally, we know from primary care staff that they are reporting that schools are facing increasing numbers of primary school children who self-harm. And this is why I also turned to Maria to see if that is something they are seeing also in primary care, because that would be quite interesting as another source of information. There are also reports in the media about worrying increases in self-harm in young children. And you can see one that is from 2018. And the journalist here reported on the soaring self-harm among the very young, and about the fact that referrals to mental health care were often rejected. And you can see from the title that children as young as 3 are self-harming. Now, I mean, some of these, of course, might be based on anecdotal evidence, so it's not really clear. There are no systematic data about self-harm beyond what we know from clinical services. And that's another news piece that Keith and myself, we were involved in earlier this year. So it was it was a documentary, but an audio documentary that was broadcasted on the BBC Radio 4 called Surviving Self-Harm. And the reporters, they used data that were supplied to them by ONS on hospital admissions statistics. And what they showed there was that there was a rise in self-harm in children aged 9 to 12 years. And that was especially in relation to self-injuries. So what we did, we recently published a paper in which we studied self-harm in children who presented to hospital in England. And we wanted to look and better understand their characteristics of this cohort of children, and also to look at the type of methods they used, and to better understand the type of problems that preceded the self-harm. We also looked at some aspects of their clinical care within while they were in hospital after self-harm, and finally the extent to which they repeated their self-harm. So we used a very large database. It's called the Multi-Center Study of Self-Harm in England, which is basically a collaboration between 3 research sites, one in Oxford, one in Manchester, and then the third in Derby, which that collaboration involves 5 general hospitals. And in the multi-center study, we collect information about individuals who self-harm and subsequently present to a general hospital. And we collect a great variety of information about these individuals. I should just say that it includes all age groups. But we collect information, among other things, on socio-demographic characteristics. We have information on the method of self-harm, on the type of problems that individuals faced prior to their self-harm, and also about the clinical care that they received and other factors. Another interesting piece of information we have in our database is about the patient's level of socioeconomic deprivation. And our indicator of socioeconomic deprivation is based on the English Index of Multiple Deprivation, or IMD in short. And just to mention that IMD is a measure of deprivation of geographical areas. So it's not a measure of individual disadvantage, but rather of the area in which we live. So in the multi-center study, we have been collecting information since 2000, and this is an ongoing study, but for the purpose of this report, we use data from 2000 to 2016. And we included all the patients who attended the study hospitals, provided they were under 13 years of age when they first attended hospital. I should just mention also that in this study, like in all of our other studies, self-harm is taken to mean any act of intentional self-poisoning or self-injury, and that is irrespective of the person's motivation, including the degree of suicidal intent. Right, so we had 387 children, so 12 years and under, in our database, out of which 65% were females. And these 387 children accounted for 650 hospital presentations for self-harm. And of those 650 presentations, 437 occurred while the children were 12 years and under, whereas additional 213 presentations occurred when the children grew out of this age bracket. So they were either adolescents or adults. So in terms of the age of the cohort, so the age ranged between 5 and 12 years, and over 60% were 12 years old when they first presented to the study hospitals. 23% were 11 years old at their first presentation. 8% were 10 years old, and 9% were 5 to 9 years when they first presented to hospital for self-harm. Okay, so the first thing to notice in this group is this change in the gender ratio across the age range. So I'm just going to use the laser pointer here. Right, so we're looking here at the number of children who presented to the study hospitals following self-harm during the study period, and this is by gender and by the age at first attendance to hospital. And we broke down the sample into age groups. So we have 5 to 8 years old, 9 to 10 years old, 11 years old, and 12 years old as a separate group. And what you can see here quite clearly, we have the boys in the blue bars and the girls in the red bars. what you can see is that between the age of 5 and 10, boys outnumbered girls, and the ratio is about 2.3 boys to 1 girl. And the gender ratio is approximately 1 around the age of 11. But then at the age of 12, it is girls who outnumbered boys, and the ratio is about 4 girls to 1 boy that comes to the hospital. And this is interesting, and it's something that has been showed also in other samples in relation to young children, because in adolescents we have more girls who we associate with the behavior self-harm, and then in young children it is actually more boys. And but I should just mention also that we know that, but it's relevant to children studied in clinical settings. We don't know much about this ratio in other samples. So the next thing we wanted to do was to look at the level of deprivation in our cohort of children relative to national figures. And so first, we plotted the distribution of children aged 5 to 12 years in England based on IMD quintiles. So these are the gray bars in the back. And then we divided the study cohort into 5 groups based on their deprivation score. And this is the red bar. And we plotted our cohort against the national figures. And the thing to see here is that in the study cohort, the majority of children, so about 60% if we take the most deprived group and the second most deprived group, so about 60% of the children in our cohort are falling into this most deprived areas in the country. And this distribution is very different from what we find for the equivalent age group across the country. And it's interesting because there aren't too many data in relation to socioeconomic disadvantage in children or in adolescents, but we know from data on adults actually that socioeconomic disadvantage is associated with the risk of self-harm and suicide. What we did next, we looked at the methods of self-harm in this cohort, and we divided the cohorts broadly into those who presented to hospital with self-poisoning, and those who presented with self-injury, and those that presented after using both methods. And we also broke the whole cohort into the younger age range, 5 to 10 years and 11 to 12 years. And what is interesting to see here is that in 5 to 10 years old, the extent to which children used self-poisoning, so this is this line, and self-injury, the second line, as a method of self-harm was pretty similar. So we have 52% versus 48%. And also in this age group, we don't have differences between boys and girls, although we should be mindful of the fact that these might be small numbers, and this is why we are seeing a non-significant difference, but it's too close to 1, so probably there isn't. And then when we move to the older children, what we can see is that about 63% self-poisoned and 31% presented to hospital after they've self-injured. So that's a big difference. And also there is a difference between males and females, such that self-poisoning was more commonly used by females, whereas in males, the split between self-poisoning and self-injury is pretty similar. We also, as I mentioned, looked at the clinical management in hospital in this cohort of kids. And I should just mention also here that the information in this slide is based on data from 2 out of the 3 research centers. Just because in the third center, the data were not as complete in relation to very young kids. So you can see that 83% of the children who came to the study hospitals received a psychosocial assessment at their first presentation. So this is the assessment where a mental health professional meets with the patient and then talks to them about various problems that they're experiencing and assess the risk and also identify some issues around their mental state. And there wasn't any gender differences here. It was pretty similar between boys and girls. Then you can also see that about 2/3 of the children were admitted to a medical bed in the general hospitals. Again, no difference between males and females. And what we looked at subsequently, we wanted to look at the type of problems that were commonly reported in relation to these children. When children receive psychosocial assessment, part of the assessment process is to understand the problems that preceded their self-harm. And so what we found was that relationship problems, especially with family members, but also relationship problems with friends and with others, accounted for much of the problems reported in relation to children who self-harmed and presented to hospital. And then we also found that study problems were identified in relation to about 13% of the children who were assessed. And also 8% of the children had some problems related to some form of abuse, and 7% of the children had a problem related to mental health problem. And here too, we didn't find any gender differences between boys and girls. So finally, what we did, we wanted to look at the extent to which children repeat self-harm within specified time frame. And we found that children in this cohort presented to hospital between once and 17 times. So that was quite a wide range. 32% of the children that presented to our hospitals had a repeat presentation at some point during the study. And a repeat episode was more common among girls relative to the boys. While a repeat presentation within the first year after the first presentation to hospital occurred in about 14% of the children. And it was about 9% in 11 years old, 18% in patients who presented when they were 12 years old. And then in those who were 5 to 10 years old, there was just one individual who represented hospital within a year. So just to summarize what I presented so far. So there is this gender ratio change with age, which starts with male predominance. And then there is this shift into female predominance around the age of 12 in terms of the numbers. And then also we showed an association between socioeconomic deprivation and self-harm. We highlighted some common methods of self-harm with some more pronounced gender differences in the methods used for self-harm in the older children, aged 11 to 12. We didn't find any gender differences in the clinical management of self-harm in hospitals, but one concerning issue was that a significant minority of children were not admitted to a medical bed, and also they did not receive an assessment, despite the fact that these are specified by national clinical guidelines for all children. And we also highlighted the finding that problems with family members and with peers are commonly cited as key problems in children's self-harm, and that fits very well with findings from other age groups. About 14% of our cohort repeated self-harm within a year, while 32% of the cohort repeated self-harm at some point in the study period. So just to kind of finish, this is the last slide I'm going to present. So most of what we know about self-harm in children is based on data from that were collected in clinical settings, so mostly hospitals. But we know that hospital statistics are just the tip of the iceberg, and especially when we're talking about self-harm in young persons who quite often self-harm and never present to any clinical services or to any school staff, or sometimes that's not even known to their parents. So we need to start collecting data on self-harm, which does not necessarily lead to hospital attendance about children. But there are all these challenges around how to discuss self-harm with children and how to research this subject in relation to children. And there are all these concerns expressed by parents and by teachers that we may get ideas into children's heads, or that we might cause unnecessary distress by discussing self-harm with these children. So I guess we need to understand first how we research self-harm in the community, in community settings, if this is going to be in primary care schools, in primary schools, not care, of course. And also we need to understand more about how better to ask children about self-harm, and how to train school staff to detect self-harm, and also how to talk to children about self-harm, and finally how to develop and try potentially effective interventions. So I'm now going to hand over. Thank you very much for your attention. I'm going to hand over now to Keith Horton for his bit of the discussion.
Good morning, everyone. I'm going to follow on from Galit to say a little bit about the iceberg phenomenon, which she mentioned at the end, to touch on some contributory factors that influence self-harm in children and adolescents in general, and then a little bit about the impact of self-harm on parents. Can I just check that everybody can see my screen? Okay, thanks. So here's the iceberg model, which Galit mentioned, and she was obviously referring in the data she presented to the light blue section of this, which is self-harm that presents to clinical services. But what we increasingly know is that there's a huge amount of self-harm that occurs in the community, and some of it may present to primary care, as Maria has been talking about, but the large part of it will not be known to clinical services. And this slide summarizes what we know about this, that in 10 to 18-year-olds, approximately 8 to 10 individuals will self-harm in the community for each young person presenting to clinical services for self-harm, particularly hospital services. So that's a huge number in that sort of lower part of the iceberg. And we know that from school surveys, approximately 15% of adolescents will have a history of self-harm, that is twice as common in girls as boys. And in the community, the majority involves some form of self-injury, whereas what we see at hospital is primarily about 75% of cases involve self-poisoning. So this level of self-harm in the community highlights the need for preventive interventions, particularly in schools, and there's some evidence from other countries of effective schools programs, online interventions, and perhaps through educating parents about possible preventive approaches. And of course, we need for those presenting to services, good quality hospital-based services and community treatment services, including, as Maria has highlighted, helping primary care deal with this problem. So I'd like to just do a whistle-stop tour of some factors associated with self-harm and indeed suicide in children and adolescents. And one is about the onset of self-harm. This slide shows data, again, from our multi-center study of self-harm in England. And this is the numbers of presentations by age, first presentations by age in females in red, males in blue. Galit has been talking about the left-hand side of this curve, the under 13s. And you can see that things start to take off at, well, at 12, but particularly 13 years of age in girls, increase rapidly in numbers with each year of age. Boys not catching up, but slowly increasing. But the gender ratio in the young adolescents is female to male ratio is extremely high. And you see at age 14, it was a ratio of 6 to 1, 6 girls to 1 boy. And this raises the question of the possible influence on puberty on self-harm. This study was done some years ago now in Australia, American school children, where they were asked about self-harm, and their pubertal stage was measured by Tanner score. And what this shows, you can see from the odds ratio, or OR on here, a steadily increasing occurrence of self-harm according to stage of puberty. So it was about stage of puberty rather than necessarily age. So there's a very strong association with having gone through or near the end of puberty, and it was particularly strong in girls. It was particularly strong for self-cutting and other independent factors which seemed to contribute were depression, alcohol use, and onset of sexual activity. Now, in a more recent study, this is from colleagues in Bristol, a study of girls, they looked at the occurrence of self-harm at ages 16 and 21, according to when puberty occurred. And what you can see is that those who experienced an early puberty were more likely to have self-harmed than those who had puberty at what's called the normative time or particularly late puberty. And so the timing of puberty was predictive of self-harm later in age. And this is a really, I think, important finding. And particularly if that study was in girls, they did a similar one in boys with a similar association, but not so marked. So early puberty seems to be associated with increased risk of self-harm. We don't know why, but it may have to do with increased risk of depression following onset of puberty, hormonal factors, possible exposure to relationship difficulties, earlier exposure to getting into relationships which might become problematic, and also disparity in development compared to peers, which may possibly lead to bullying or other effects. And clearly this is an important area for research and for potentially developing help for children and adolescents, particularly those going through an early puberty. I'd like to also touch on some other issues. Sleep problems. We know that sleep problems are associated with self-harm in young people, possibly partly related to depression. And of course, one particular influence these days may be the use of mobile phones. In this study, a large proportion of youngsters were looking on their phones during the night, and an astounding figure of 1 in 10 were checking at least 10 times a night. And of course, it's not just the disturbed sleep, but it might be the content of what they were seeing on the phones may have added to problems and to risk. We know that interpersonal and media influences are particularly important in young people and with regard to suicide and self-harm. Exposure to others self-harming is a risk factor, and it seems to gain particularly strong in girls and for self-cutting. We know that clusters of self-harm and suicide are relatively common in the young, more common than in adults. And we distinguish between what we call point clusters, in other words, where clusters occur in a similar, over a period of time within a particular location, such as a school, inpatient adolescent psychiatric units, or possibly at iconic sites. And then mass clusters, which are geographically spread clusters, and where social media might be a powerful influence in this regard. We produced a review on this last year. It was published in Lancet Child and Adolescent Health, and I'll make that available to the organizers in case they'd like to distribute it. And in England, we developed this clusters guide for Public Health England to try and help local agencies when confronted with a cluster, be it of suicide or self-harm. And of course, they often go together. And that has been quite widely used, sadly, in a way. But I think people have found it helpful because there's usually panic when people think a cluster is happening. And we know also media influences can be particularly important in relation to self-harm in young people. and that suicides tend to be disproportionately reported in the media. Some of you will remember the cluster of suicides in Bridgend back in 2008, which involved primarily young people, including adolescents. And this was a couple of examples of the dreadful news reporting that went on then. Thankfully, things have much improved in the way suicide and self-harm are reported in the media, but this sort of thing can serve to what we call normalize suicidal behavior and self-harm, such that it might increase the likelihood of it occurring. And then, of course, there's the problem, the question of accessing information on the internet about self-harm. We know that internet sites are often accessed by young people prior to self-harm, that suicide sites which promote suicide and self-harm, encourage suicide and self-harm. There's detailed information on methods of suicide and self-harm. We know that these are often accessed by young people prior to a self-harm episode, particularly a high intent one. And with regard to social networking sites, so the evidence seems to be these can be both helpful in terms of providing support for individuals, but in some may be harmful and actually contribute to risk. And then there's the problem of cyberbullying, which of course is can be particularly powerful. We know it's linked to self-harm, not just in the victims, but also in perpetrators. And the problem here is, of course, it can occur at any time, in any location, and can be a particularly powerful influence. So I'd like just to end by saying a little bit about the impact of self-harm on families. We carried out a study a few years ago of 37 parents, nearly all mothers. It was very difficult to recruit fathers for this study. We had a range of participants from across the UK. And I'm going to just summarize the findings of what they told us. First of all, and unsurprisingly, they often reacted to the discovery of their child's self-harm with confusion, disbelief. It often had a negative impact on their emotional states, but also could lead to mental health problems, and some had to seek psychiatric care themselves. There were sometimes financial problems, particularly where children had to be taken to appointments in other parts away from their local district. Sometimes there were impacts on partners and on their relationship, also on the siblings of the child involved, and indeed on wider family members, and some evidence of disapproval, for example, from grandparents. And some parents talked about becoming socially isolated because they're ashamed of the child's self-harm and worried what other people would think about them. And their parenting strategies were often affected such that they treated both the child who was self-harming, but also other children very differently, which could be problematic. And in terms of care, they considered the attitude of clinicians to the child's self-harm extremely important, and they particularly disliked, both they and their children, a sort of tick-box approach to risk assessment, for example. They wanted to be involved in treatment, and they were keen that there were resources and specific guidance readily available. And as a result of this, as my last slide, we developed some resources. At the top is a website, the healthtalk.org website, which has a site on parents' experiences of self-harm. And this includes clips from the interviews from our research, video clips arranged thematically. And that's freely accessible through the health.org website. And then on the left, we produced this parents' guide for helping them cope with the child's self-harm. This is both in hard copy and online, it's tens of thousands of the hard copy have been distributed over the last 3 years of this, and we've received some very positive feedback. And lastly, we've produced this guide for schools, which also is available online and in hard copy. So thanks for your attention. That was just a whistle-stop tour about some aspects of self-harm in children and adolescents. Thank you.
Thank you both very much indeed for that contribution. This time, Aine is going to compare the questions that are coming in. And so I'll hand over to Aine.
Yeah, thank you. Such interesting presentation. We've had some really interesting questions as well. So one of them that came in was just a question around whether you could make a comment on whether younger children are overlooked more, because they often have kind of bumps and cuts if they're very, very active, and whether you feel that that maybe is resulting in it being underreported, or how you feel those figures look.
Lee, do you want to?
Yeah. It is possible that a minority of children are overlooked because you expect them to have the bumps and cuts. But I think with self-harm, from the little I know about self-harm in children, it's not going to look like a bump or a cut. It's something that can look like bites and head banging. So you sometimes see the behavior itself. And correctly, if I'm wrong here, Keith, so it is visible. I think what happens often is that it is being seen, but the people who come across it maybe don't exactly know what to do with it. It's unless you have the training and you understand. If you're a teacher in a school and that's what you see in kids, it's quite hard to know what you're supposed to do. So that was my point about training.
Yeah, it's worth adding that some of the, particularly boys, use very serious methods that could look quite potentially life-threatening. So they wouldn't be missed. And that was one of the striking findings for me. It was one of the things that got me interested in looking at this younger age group, hearing about a particular case of a young boy who attempted using a very serious method.
Yeah, no, that's great. I think that answers the question. Another one that we had in was about the link between, I know you touched on it already, but whether there's anything more you could say on the link between kind of self-harm and either abuse or kind of sexual assault or that side of things.
Well, shall I come in here? I mean, we know that there's increased risk of self-harm and suicide in relation to abuse, domestic abuse, sexual abuse, physical abuse, and also emotional neglect. So abuse, it may not just be acute events, but protracted neglect. So these are strong, powerful factors. And they may be factors not just in young children, but factors that, we know they are increased risk later on in life because of the scars, the emotional scars that are left by such experiences. And they may be reactivated, for example, when there's a relationship problem in young adulthood, which may increase, vulnerability.
And if I should just mention here that what I mentioned in relation to abuse as a problem, it could be one of many problems that was present before the child self-harmed and ended up in hospitals. It's not necessarily kind of the cause or the reason. So there could be multiple reasons as well. In case that was kind of the proportion low, relatively low.
Great. Yeah, thank you. And then we might just have one more question. So it's just actually a late question that came in, but sounds very interesting. Just around, I suppose, single parent families and whether there's a difference there in terms of single parent families that the research that kind of was shared seems to indicate that both parents might be protective, whereas our single parents or children of single parents at more risk.
Shall I start? I mean, I think the key thing is about the, in those with both parents to live together is the nature of the relationship between the parents, and that's the crucial thing. I think there's some evidence that living with just one parent may be associated somewhat with increased risk, but not. I don't think that's very marked. I think the crucial thing is, is it a warm parental situation, be it one parent or two parents? I think is the crucial thing here.
I think, as Keith says, but I should just also add here that in single parents households, sometimes there is more worse socioeconomic conditions, and that might be linked to an increase in self-harm rather than being single or not. So if there is a supportive and stable family household, it's less observed, like this risk of self-harm. That's from what I know. But also I should also say that it depends on the mental health of the parent itself, because they might have an influence on their next generation in terms of risk.
Yeah, excellent. That's great. Thank you. Now we had one more question just asking about LGBT issues, but I think that's anticipating Hazel's talk coming up very soon. But if there's anything that you guys want to say on that or want to comment on that before I hand back to Eilis.
I feel it's better answered by Hazel, because it's not my area. I don't know too much about it, so I don't want to say things I'm not. Unless, Keith, if you want to comment.
No, I think we'll leave it to the expert.
To the expert.
So Galit and Keith, thank you both so much for that fascinating presentation. And again, just to say to people that we're going to be taking a short break now, and we will come back at 11:35. And I leave my screen on so that anybody who joins us knows that they have joined the webinar. So please stretch your legs, get yourself a cup of tea or coffee. And we're coming back to a presentation by Dr. Hazel Marzetti, who's going to be presenting on a topic that I call the fertile ground, and it's about understanding the role of stigma, discrimination, and harassment as contributors to suicidal distress amongst LGBT plus young people and how to intervene in it. So we look forward to Hazel's contribution after this very short break. And again, thank you, Galit and Keith.
Thank you very much. Thank you.
Eilis, are you wanting me to share my slides now so that we can see if they're working, or will I just wait until after the introduction?